All right, well, I'd like to start off this seminar with a few slides giving an overview of the Secondary Data Analysis Seminar Series and the Biostatistics, Epidemiology, and Research Design core of the Center for Clinical and Translational Sciences. So the goals of the Secondary Data Analysis Seminar Series are to first educate investigators about existing data and how that data can be used for research, partner with investigators interested in performing secondary data analysis, and assist them in developing successful research proposals. Increase awareness and visibility of CCTS BIRD members and the resources. The seminars are on the third Thursday of every month from 12 to 1 p.m. You can see here the current schedule of the talks in the series. So in addition to today's talk, the current schedule includes upcoming talks on Medicare and Medicaid, the National COVID Cohort Collaborative, PCORNet, and several NIH data archives and repositories. For more information and registration, you can click on the link at the bottom of the slide there. Now, the mission of the BIRD Core is to ensure that research conducted under the construct of the CCTS is based on sound and appropriate statistical design and principles. Specific objectives include to collaborate with CCTS investigators at both Ohio State University and Nationwide Children's Hospital in all aspects of quantitative translational research, design, reproducibility and scientific rigor, and statistical analysis. Train investigators on research design, reproducibility, and biostatistics as they relate to clinical and translational research. And identify innovative and effective statistical methods in response to specific project needs that enhance the quality, design, interpretation, and communication of results. The BIRD Core has a proven recipe of success, including rigor in study design and analysis, expertise across a broad spectrum of biostatistics and epidemiology, established collaborations with multiple investigators, innovative work in biostatistical methods, productivity in grant submissions and publications, and many years of experience on NIH and other funded grants. There are multiple ways that we can help investigators, which starts from the genesis and formulation of research hypothesis to the design of the study, and finally statistical analysis and modeling. A summary of the BIRD Core members appears here. We are a mix of faculty and staff biostatisticians and epidemiologists across the College of Medicine and the College of Public Health. And with that, I'm going to hand it over to Dr. Mike Pinnell, who's going to talk about the Women's Health Initiative.
Thank you, Guy. So, if you may have noticed on that slide that Guy presented at the end, my name is Mike Pinnell, and I am also, like Guy, I'm a member of the BIRD Core of the CCTS. I am also a co-investigator on the Life and Longevity After Cancer study, which is an ancillary study of the Women's Health Initiative, which is what we're going to be talking about today. So the goals of my presentation today are as follows. First goal is to make you more familiar with the WHI investigator data sets and how they can be used for your research. And then I'm going to go over a little bit about the process for accessing the data and how to propose a manuscript. And I need to make an acknowledgement here. So the majority of these slides were actually prepared by Amy Lehman, who used to be a member of, used to be here at OSU, a member of the BIRD, as well as a member of the Midwest Regional Center of the WHI. So she gave me her permission to use these. I made some modifications, but again, most of it's hers. And in particular, I want to acknowledge there's a lot of bells and whistles in this, presentation, animation, and some sound effects. And that was totally due to her efforts, not stuff that I added on my own. Okay, so the Women's Health Initiative, right? So here's the background for, or excuse me, the outline of what we're going to be going over. So I'll start with a quick background and overview of the WHI. Then I'll give a description of the data, followed by some briefly some examples of how it's been used in research here at OSU. Again, that'll be very brief. Talk a bit more in detail about the challenges and limitations of the data, and then give you an idea of how you would access the data and propose a manuscript. And then conclude by pointing you in the right direction for additional help. Okay, so some background. So here, this is kind of a one-sentence summary of what the WHI is. The Women's Health Initiative is a long-term national health study focused on strategies for preventing heart disease, breast and colorectal cancer, and osteoporotic fractures in postmenopausal women. So the study actually has its own website, whi.org, where you can find out a lot of information about the study. It has been funded over the years by the National Heart, Lung, and Blood Institute of the NIH. And the study launched way back in 1993. And the main study period was between 1993 and 2005, although there has been extensions for an extended follow-up on the participants, first one occurring between 2005 and 2010, and the second just ending recently. So that lasted another 10 years from 2010 to 2020. There's also been some ancillary studies. I mentioned one that I'm involved with, the Life and Longevity After Cancer, LILAC study. But today, we're really just going to be focusing on the first two bullets here. Data you get from the main study and the extensions. That is officially known as the WHI Investigator Data. That's available through the WHI website, by request through the WHI website. If you want data from the ancillary studies, that requires a different mechanism because it's a different set of principal investigators you would have to go through. And I think the plan is to cover some of that in a different seminar, maybe this fall. So as I'll mention in a moment, the WHI is a collaboration with between universities throughout the US, but its sort of official home, I would say, is the Fred Hutchinson Cancer Research Institute in Seattle, because that is the clinical coordinating center. All right, so who's in this study? So it was a lot of postmenopausal women, 161,808 is who was recruited. These women had an average age of about 64 years old, range 49 to 83. And there are two components of the WHI. So people often refer to the WHI itself as a study, but it's actually consists of a few different studies. First off, it consisted of 3 different clinical trials. The first clinical trial technically it was 2 different clinical trials. These were these hormone trials that looked at 2 different treatments, 2 separate trials. One trial looked at treatment with estrogen alone, and another looked at a combination treatment of estrogen plus progestin. There was another clinical trial that looked at a dietary modification, enrolled about just under 50,000 women. Talk more about specifics behind that in a moment. And then there's also another clinical trial that was a supplement study of calcium plus vitamin D, right? And as you can see in this Venn diagram, there was some overlap between who was enrolled in these different clinical trials. So if the total number of women who enrolled in the clinical trials was 68,132. Again, those ends don't sum up to that because of the overlaps between the studies. So there were clinical trials, and then there was also an observational study that enrolled almost 94,000 women. This consisted of women who were not eligible for one of the clinical trials or declined to participate in one of them. So again, across both the clinical trials and observational study, those two numbers there sum up to the 161,808. So as I mentioned earlier, WHI has been a collaboration of, of centers throughout the US. So this map here shows, the participating centers. But the clinical trial and observational study was conducted at 40 different major clinical centers across the US, as indicated by this map. Does a pretty good job in capturing most of the country, although, the Rocky Mountain region didn't really look like it was very well represented. There's two different colors of dots on this graph. They're regular clinical centers, and then also noted here what we call, I'm noting as minority clinical centers. So those were clinical centers that were recruited to increase the diversity of the sample. So here's the racial makeup of the WHI participants. As you can see, the vast majority were white, non-Hispanic white, just about 83%. There was a very good sample of non-Hispanic Black women in the study. And, the numbers in some of these other racial groups look pretty good as well. But one thing that from experience, I know that some of those numbers start to come down once you start doing subsetting for papers. All right, so the main WHI study started off with these 40 different major clinical centers noted on the map. In extension, the clinical centers were kind of collapsed or combined into different regional centers. So first regional center, I guess, is the Fred Hutchinson Cancer Research Center, which is the clinical coordinating center for the study. And the PI is Garnet Anderson. There's also a Northeast Regional Center with the primary site being at the University of Buffalo and a secondary site at Brigham and Women's Hospital, Boston. Southeast Regional Center at Wake Forest University. West Regional Center located primary site at Stanford, secondary site at the University of Arizona. And then there's our center, the Midwest Regional Center. We are the primary site here at Ohio State. Becky Jackson is the PI. There's also a secondary site at the University of Iowa. All right, let's talk about the goals of the WHI. So it differed depending upon what specific sub-study we're talking about. So the hormone trials. The interest there was in knowing if combined hormones, that combined therapy of estrogen plus progestin or estrogen alone could decrease the incidence of heart disease and osteoporotic fractures. As a secondary outcome, they also wanted to know the association between the hormone treatment and breast cancer, because it was known going into the study that that was a possible adverse, could be a possible adverse effect for long-term treatment with estrogen. So they wanted to see if the treatments actually, as a secondary outcome, increase the risk of breast cancer. And the dietary modification trial, what they were interested in there was if a low fat and high fruit, vegetable and grain diet could decrease the risk of both breast and colorectal cancer, as well as decrease the risk of heart disease. And then the calcium plus vitamin D trial, or CAD trial, they wanted to know if this supplementation could decrease the risk of fractures and colorectal cancer. Then there's also the observational study. So the goal there was to see if, evaluate whether or not changes in lifestyle, health and other risk factors were related to different disease outcomes, such as, cardiovascular disease, cancer, and diabetes, as well as look at the changes in those factors, the effect of changes on those factors on mortality. All right, so what were the main findings of these trials? We'll focus on that. So first, the hormone trial. So fortunately, there were some negative findings from this trial. They found that in the study that looked at estrogen alone, That treatment increased the risk of stroke and blood clots in the legs. In the combined treatment trial, they found that estrogen plus progestin increased the risk of breast cancer, heart attack, stroke, and blood clots. So those studies were actually stopped early because the risks outweighed the benefits. But there were some beneficial effects of the treatment. For the estrogen alone treatment, they found that it decreased the risk of hip fractures, but didn't find a significant increase in heart disease or colorectal cancer risk. And there was also this sort of interesting association that was observed that it actually caused a possible decrease in breast cancer risk, which was contrary to what I mentioned earlier was their expectation. And then in the combined treatment trial, they found that actually that treatment decreased the risk of hip and other fractures, and it also decreased the risk of colorectal cancer. But again, those benefits were not judged to outweigh the risks. And in the dietary modification trial, what they found, unfortunately, was there's no significant reduction in the risk of coronary heart disease, stroke, or cardiovascular disease. And they found a non-significant decrease in breast cancer risk. It was like a hazard ratio that indicated a 9% decrease due to treatment. In the CAD study, again, it's kind of the results of the treatment were kind of modest. They found a small, but it was statistically significant increase in hip bone density. There was not a statistically significant decrease in hip fracture risk, but there was unfortunately an increased risk of kidney stones. So, although, you may look at these results and think that, well, the results weren't too promising from these clinical trials, but actually even though they weren't, you might think that because they didn't have profound effects on, their intended outcomes, they did have pretty big impact. And that was particularly with the hormone trial. And there was an interesting paper published back in 2014 that looked at the economic return from the investment in the combined treatment estrogen plus progestin clinical trial from the WHI. And what they found was this. Here's a highlighted text from that paper. It says that the WHI E plus P trial changed our understanding of combined hormone treatment risk-benefit balance. It was a major driver of the decline in hormone therapy use in the US between 2003 and 2012. And so this is the interesting part, right? Their findings suggest that these investments yielded a return of $37 billion in net economic return in the past decade, right? So it was, even though, again, it didn't have the benefits that they were hoping, this treatment didn't have the benefits that they were hoping, it was a wise investment on the part of the NIH. Okay, so let's talk more about what the data are. So the investigator data actually consists of 107 different data forms. Those forms consist of forms that collected data on demographics, what study women were enrolled in, their eligibility for being in the different studies, as well as their adherence to the treatments they are assigned in the clinical trials. There's also information on diet in these forms. That includes food frequency questionnaires, as well as computed nutrient intakes. There's medical history information. This includes self-reported diseases at study baseline, the women's reproductive history, family history of disease, and there was also follow-up data on exams completed during the study. There are also medical and physical measurements. So this includes height, weight, blood pressure, bone density scans, ECG among echocardiograms among women who are in the clinical trials. Also, amongst women in clinical trials, there are tests of functional status. In the hormone therapy studies, there was Pap smear results, and also there are some breast exam results for women in the clinical trials. There's also information on medications the women were taking, their follow-up data on their current medications and supplements, and there are also surveys on their barriers to taking medications. There's data on psychosocial and personal habits. So this includes smoking and alcohol use, physical activity, including computed med hours, depression, social support, sleeping habits, self-rated health, activities of daily life, a lot of good information. Specimen results, part of that includes lipids, glucose, complete blood count. And there's also outcome data, which I'll talk more about in a moment, that consists of both adjudicated outcomes and self-reported outcomes. All right, so when were these data collected? Well, some data was collected at baseline and at selected follow-up time points during the study. But that was not true of every single item. It really depended upon what that data component was and actually what the study membership was of a woman. So this here is a data collection frequency grid that used to be available on the WHI website. Information is still there, though it's presented in a different way. And so in this grid here, what we see, if you see an X, that corresponds to data that was collected on all women, and the different letters denote data that was only collected on women who are in a certain clinical trial. And if there's a percentage, that means that data were only collected on a percentage of women that happened at certain time points during the study. Right, and as you can see, right, for the clinical trials and observational studies, right, there's quite a difference in sort of the richness of the longitudinal data. And I'll get back to that in a moment. All right, so let's look at an example, current medication use. In the clinical trials, participants had this data collected at baseline and at years 1, 3, 6, and 9 in the study. But the observational study participants had much fewer measurements. They just had it collected at baseline and year 3 of their follow-up. As I mentioned earlier, there were adjudicated outcomes collected in the study. And along with whether or not an outcome occurred, the WHI data sets have information on the timing of the event or the outcome, where time is recorded in terms of days from either their randomization to their clinical trial arm or enrollment in the WHI. So these adjudicated outcomes include cardiovascular outcomes, CHD, heart attack, stroke, cancer, bone fracture, and death. Okay, so we have been very productive actually with these this WHI data here at OSU. So here's some examples of some past papers that have been accepted, that are led by OSU investigators and members of the Midwest Regional Center. All right, so there are several papers written on cardiovascular disease, as noted here. Papers on stroke, fracture, and several papers on cancer. And I circled this last one here because this is the only one listed that I was involved with. And I saw that the first author is actually on this, in this meeting as well. So this was a study where we looked at changes in the longitudinal trends in sleep quality and duration following breast cancer diagnosis. And we found had an interesting finding that the age-related decline in sleep quality actually decreased following a breast cancer diagnosis. And this looked like it may have been due in part to depression decreasing after breast cancer diagnosis. So a very interesting finding from the WHI data. All right. So one thing I want to spend quite a bit of time on now is the challenges and limitations of working with these data. because I just want to give you a fair warning before you decide to dive into things. First off, these data are observational, right? Particularly for your purposes, right? That you'd probably be using it for. You're going to be doing a secondary data analysis, right? So any sort of analysis you do are going to require consideration of confounders, of the associations you're observing. So just keep that in mind. Also, there's some limitations in terms of the data management, not a major limitation, but just some steps you have to go through in order to get the data in working form. So what you would receive from the WHI statisticians, or actually when you, not necessarily that, when you download the data from the website, is you'll get an ASCII file with a header row containing your variable names. And so it looks something like this here, right? This box off to the left, right? What you'll also get when you download the data is you'll get a SAS program that can be used to create a data set, right? So it's kind of nice is they give you formats for the different variables, so you don't have to always be worrying about looking at a code book. So you can convert, you run this program, off to the right here in SAS, and you'll get a SAS data set you can use. But no, you don't have to use SAS. I mean, obviously, if you read it into SAS, you can convert it to a different format. You could also, I guess, read the ASCII file into some other software package, like maybe R. But, my personal advice would be, if you can, use SAS because, again, with the formats that are coded up, it reduces the amount of time you'll have to be referring to a code book. Okay. Another thing to keep in mind if you work with these data is you don't get any dates, right? That's because, that's done for the purposes of, protecting, human subjects data, right? Because if you attach a date to anything, it's considered protected health information. So just to give you an idea of sort of the limitation of this, let's say, you want date of birth, right? But you can't get that from the WHI. What you'll get instead is someone's age and enrollment, okay? So you can't use date of birth to calculate their current age. You also don't get their date of enrollment, right? In fact, date of enrollment is denoted as like time 0 in the WHI. Right? All forms will have like, there'll be a time on the form, right? So, sort of like instead of the date of the form, and the time will be denoted as time since enrollment. Right. So again, I kind of just mentioned this, there's no date of measurements on any of the forms. But what you'll get instead is, the days the measurement was taken since enrollment. All right. So to give you an idea of maybe some of the hoops you have to go through to calculate like certain time variables for your analysis. Right. Let's say you had someone who was born on January 1st, 1940. They completed their screening form. Form 2 on June 5th, 1995. They're enrolled on July 1st, 1995. They had a hip fracture on February 1st of 2004, and they died on January 1st, 2010, right? So here's the information the WHI data sets will give you about all this, right? So the time they were enrolled in the study will be called day 0. You won't get their date of birth. You'll know that they're age 55 at the time of their enrollment. The time of their screening form, right, is 26 days before they're enrolled in the study. And you'll know from the data that they experienced a hip fracture 3,137 days after enrollment, and they died 5,298 days since enrollment, right? So again, one thing you often have to do with the WHI data is, sometimes you have to, you kind of have to work around this issue that you don't have dates, and you'll be, subtracting time variables to maybe get a time that you're interested in. All right, another limitation is that for the adjudicated outcomes in the study, there's only information on the first recorded event. No recurrences were recorded, okay? So, for cancer, just their first diagnosis of that type of cancer, you don't know if they actually had a recurrence. Another big limitation of the data is the study population, because you need to keep in mind that the women who enrolled in this study live close to an academic medical center. So in general, you would expect them to be more educated, more affluent than the general population. And then, again, this sample is probably not going to be representative of the entire US. Also, another thing to keep in mind is that women who were enrolled in the clinical trial and observational study were very different, right? There are different eligibility requirements. So you have to think about that in deciding whether or not you want to combine those two different portions of the WHI. All right, so first, now I have a warning for you guys because Amy added a sound effect here, so I don't want to scare anyone. All right, here I go. All right, so here's the tail of the tape. Differences between the observational study participants and clinical trial. So, there are the ends at the top I mentioned before. The observational study had slightly fewer Black or Hispanic participants. A big difference you see here is that the clinical trial, there are more obese participants in the clinical trials. People in the clinical trials had lower income. They're less likely to be a hormone user at baseline. They had a lower percentage of a history of cancer, family cancer, or a history of cancer. They're less likely to, be eating healthy, low fat, low cholesterol diet. And, the higher percentage didn't have health insurance in the clinical trial. So again, you have to consider these types of differences if you actually want to combine the data across these two different sort of class of studies in writing a paper. All right. Another big limitation is the timing is related to the timing of the measurements, okay? First issue is that anything that occurred prior to WHI enrollment, such as, some sort of medical condition or event, those are only self-report, right? They weren't adjudicated. So here's an example, right? At WHI baseline, women filled out this reproductive history survey. And one question that was asked is whether or not a woman had their tubes tied, okay? And so that was self-reported as yes, no, okay? So here's the numbers in the study. They also self-reported an age when their tubes were tied, right? As you can see here. So note, again, limitations, this is recall only. This was not verified by looking at medical records. And, they self-reported the age, tried to minimize, possible sort of errors and recalling the age by reporting things in a range. But again, there probably could be some, misspecification there. And then, there's some missing data here. Some women actually, said they had their tubes tied, but then didn't report the age at which their tubes were tied. And that's another issue, although not really going to spend much time on that during this presentation, is you often have to deal with a lot of missing data when working with the WHI data sets. All right. Another big issue with timing is that the frequency of the measurements vary. So one common example we see has to do with BMI, because I've had to deal with this, and my colleagues here at OSU have had to had papers where we're interested in looking at how changes in BMI are related to different outcomes. Okay, so there's some issue with looking at BMI in the WHI. So BMI was collected on Form 80. That's form collecting information on physical measurements, right? Captured height, weight, and then BMI was calculated from that. And one thing to note is the frequency of Form 80 was a lot different between the clinical trial participants and those in the observational study, right? Another thing to note, that Form 80 wasn't completed during the extension studies, right? So there's only information on, measured BMI up through the end of the main WHI study. All right, so again, differential follow-up in terms of BMI across the CT and OS participants. For the observational study participants, they actually do have annual weights, but it was self-reported in surveys. Whereas for the clinical trial participants, they did have annual clinic visits where they did get weighed. Also, so actually, I want to make a comment here about this. So that's something you need to think about when you're combining data between observational study participants and clinical trial participants, right? You have to think about, what weight information am I going to use, right? I tend to just use the measured values. And for one reason, it's a little odd, in my opinion, to be combining both self-reported weights and measured weights. But something to consider. Another issue related to this timing issue mentioned above is the fact that the information on adjudicated outcomes was collected up through March 1st, 2019. So think about the time frame in which there's measured BMI, right? That ended in 2005. So if you're interested in maybe looking at how BMI is related to some sort of event like cancer, right? The timing of that last BMI measurement could be a considerable number of years prior to that event occurring, right? So, the usefulness of that BMI measurement and sort of predicting that outcome is maybe a little questionable. All right, so, try and wrap up here in about 5 minutes-ish. So I want to talk now about how you access these data. So you need to visit first the WHI website. There's 2 different types of proposals you can fill out on the website. You can fill out a paper proposal where you're going to be using the data that's already been collected from the WHI studies, or you could actually propose an ancillary study in which you collect new data. But we're just going to be focusing on the first case where you want to propose a paper. So there's like a 2-step process here for getting approval to write a paper, access data, and write a paper. First thing you need to do is you need to submit a proposal to the Publications and Presentations Committee. And there's a proposal form that you can download from the WHI website as noted here. All right. One thing that's mentioned on that proposal is that you need to specify a WHI sponsoring principal investigator, right, to collaborate with on your paper. And if you click on that link I give you down below, it'll give you the list of possible sponsors. There are 2 from Ohio State, Becky Jackson I mentioned earlier, and Electra Paskett. All right, then after you submit your presentation, or excuse me, your publication proposal, and it's been accepted, then you can download the data, right? So if you want to download the data to do the analyses yourself, or if you have your own personal statistician, they'll be doing the analyses for you, you have to fill out a data use agreement in order to get access to the data. If you don't want to do that, you could potentially work with a WHI statistician, such as one of the members of the Midwest Regional Center here at Ohio State. Another thing I want to note is that after you do the analyses and write up the paper, before you submit it, you need to submit that paper back to the PMP committee for approval. Okay, so one thing I want to mention is before you go through the process of putting together a paper proposal, I recommend you go to the WHI website and look at their query builder. because that can give you a sense of whether or not, you can the WHI can really support your plans for the paper, whether or not there's sufficient sample size. So through the query builder, you can get numbers of participants by, their study participation, right? So by clinical trial versus observation study, and time period, the main WHI study and extension study. You also get information about race and ethnicity and age. And then you get information about, how many participants had a particular outcome that you're probably interested in looking at. And then also information on, availability of certain specimens and test results. So here's an example of a query builder that was, or an example implementation, I guess I should say, of the query builder that Amy did. Did this the other day. Numbers are a little bit different, but the idea is the same. So what Amy was looking at was she wanted to find the number of women in the study who had a hip fracture and were a participant in the observational study. Okay, so that query, resulted in 2,236 participants, and you get a table that looks like this, right? So it gives you the breakdown of that 2,236 by race, it would give you, if you chose clinical trial participants, give you a breakdown by, what clinical trial they participated in. Here, everyone's observational study, so, everyone's there. It also tells you whether or not, or how many women were involved in the 2 extension studies. And then there's this, in the second extension study, there are 2 different cohorts for the outcome collection. There was the medical records cohort and a self-report cohort. So, as indicated by those names, some women had their outcomes confirmed by, or outcomes obtained through medical record review, whereas, another set of women had it through self-report. Right, so, here's the information for accessing this query builder. Just go to the website and you select the query builder under the resources tab. Okay, so wrapping up here, if you have more information about the WHI, I highly recommend going to the website. If you want to request support from the bird on a WHI paper, we recommend, or we would prefer, that you go to this link on My CCTS and fill out a project proposal. Alternatively, you could also submit a ticket to the Center for Biostatistics for help on a paper, although again, we prefer the first mechanism. And that's it. So now I am open for questions.
Thank you very much, Mike. Are there any questions from the audience? So I'm going to kick it off with one question. I'm curious. So you don't have birth date. You have age and enrollment. You don't have date of enrollment. Do you have year of enrollment?
No.
Interesting. So how do you deal with temporal changes in treatment that might occur that would potentially impact outcomes?
So what kind of treatment? So like changes in medications that participants are taking?
Well, just if you have someone that there's a decade difference in enrollment date, that could just impact a variety of things as healthcare improves. So I don't know if that's something that you have to consider or address when you look at these data.
Yeah, so I don't know if someone else on the call can answer this better. Maybe Eric is involved. I don't think you're going to see, like, in terms of their enrollment in the WHI. So the main study, what was it? It was 1993, I said, through 2005. You're not going to see like a 10-year difference in their enrollment. Now,
Okay.
it can be like a 10-year difference in like when like they are diagnosed with cancer. We see that a lot, yes. But yeah, and enrollment, no, that's not going to be an issue. I don't offhand, I'd have to look it up again. Yeah, so Michelle just wrote it's 1993 to 1998, right? So, you know, it could be a 5-year difference.
I see. Okay. So not really a concern.
There is an alternative method that we are able to get dates, but there are some extra hoops that we have to jump through, and all of the analysis has to be done on like the secure WHI server, and we aren't able to bring any of that into we have to get everything approved, and it goes through somebody with WHI, and they send me the results. We've been doing that with a couple of cancer projects recently, where we want to look at whether someone's treatment for cancer was concordant with the guidelines of their year of diagnosis. And so we've had to use it. You have to get some extra approval, and it's also, I think, a $3,000 cost to use their data enclave. But if you really want to work on something that would require dates, there are avenues for doing that.
Oh, that's very helpful. Thanks, Eric. And actually, you mentioned the cost there to get that. So Scott had a question in the chat, and I don't know, Mike or Eric, if you can answer this. He was asking, are there costs associated with accessing WHI data in general?
Your time. Put it together as a proposal, because sometimes you have to go through multiple iterations. So I guess that's the main cost, but no. Just only if like Eric mentioned, if you want that type of information, like kind of the protected information. But again, you know, they wouldn't actually send that information to you. They would give you access to their data enclave, or you work with someone who has access to the data enclave.
All right, and before, and while I have everyone on still, I'm gonna go ahead and put in the chat a link to a Red Cat feedback survey. And hopefully that goes through, yep. So if everyone would take a moment when you have a chance to fill out that survey. Another thing to mention is that this is being recorded. It will be posted to the CCTS webpage. We'll follow up with everyone via email with a link to where that'll be posted. We'll also be preparing one-page cheat sheets for each of the data sets that we're presenting in this series. That'll basically just have you know, important links and important notes about the data and how to access the data. So all that will be, you know, will be available on the CCTS webpage. Are there any other questions or? Well, Mike, thank you very much for giving this talk. I think we all found it very helpful, very informative. And you know, personally, I learned quite a bit. So thank you very much.
All right, thanks.
And hope everyone can join us for future presentations in the series. If you're interested, please check out the upcoming talks. So thank you very much. Have a great day, everybody.